Thank you, Penny, and thank you, Rod, for having me here, talking about my pet topic, which is truth, trust and evidence. And one of the things I've noticed in the course of this conference is that there's a lot of talk about truth and trust and evidence, and I've learned a new concept, which is consilience of evidence. Anyway, I'm hoping that thank you, Grant, I'm hoping to get to that idea of consilience of evidence. I'm starting with a really big claim, and that is that all knowledge is perspectival. And what I mean by this is all knowledge is partial and situated. It's limited, and at the same time, it's a way of seeing, and at the same time, a way of not seeing. How you look, the eyes or lens that you use determines what you see. And why this matters, there's lots of conflicting claims to truth out there in the nutrition and medical space, and people are confused, and we've heard that this conference. And then they get angry when they realise that so much conventional and nutritional advice is wrong and frankly harmful. So, who should you believe? So most of us make assumptions about truth, like that there is a thing called capital T truth that's out there waiting to be discovered, set in stone and cannot be challenged, a bit like the Word of God. And that science and the scientific method are the way to discover this capital T truth. And most of us assume that truth can be trusted and that it is backed by evidence from the science. So I'm taking a step back from that assumption and questioning those assumptions and asking, how do we know that we know? And the official term is epistemology. So a couple of terms I'd like you to know: paradigm and episteme. Terms with similar meanings, and I'll tend to use them interchangeably. The episteme is the intellectually certain knowledge. So we can talk about the medical episteme, the things that we take for granted as being true. So we're talking about consensus reality, and doctors practice within a medical paradigm. We're trained to think in a particular way, and we think differently to other healers and other traditions or paradigms. For example, naturopaths or shamanic healers, very different paradigms. Today, I'm examining the medical paradigm, the body of medical knowledge, and its claims to truth. Because we, being doctors and patients, rely on this body of knowledge as being accurate, truthful, trustworthy, and we assume or claim that it will lead to the best health outcomes. So you wouldn't be here at a low-carb conference unless somewhere along the way you'd grappled with questions such as, who can I trust with my health? And if you're a clinician or a scientist, what science can I trust? And in relation to low carb, can we trust low carb? What is the evidence? Can we trust the evidence for low carb? So I'm starting with more about perspectivism. Back in the 19th century, philosopher Friedrich Nietzsche made this really radical claim about truth and knowledge. He said there is only perspective knowing. A perspective provides a partial view of something, and if we really want to understand a thing more fully, we need to examine it from many different angles. We need more eyes, different eyes, for a more complete understanding of a thing. Now, here's a simple imaging analogy of different perspectives and what they allow us to see. These 4 images are looking at the same thing, but they all provide different information. And the information that they provide may or may not be useful in the circumstances. And it also reminds us that a way of seeing is simultaneously a way of not seeing. So I'm not saying that we can't know anything for certain. I'm arguing that all knowledge is limited and to a greater or lesser extent uncertain. The value of knowledge, I believe, lies in the answer to this question: does it work? And this is the big question. How does this knowledge help us or hinder us in the real world? In other words, the value of knowledge lies in its pragmatic application. And the big question that doctors and patients grapple with is, what works best? What gives us the best outcomes? And by the way, humans, doctors and patients, we love predictability and certainty. And we really dislike uncertainty. We want to know that an intervention is going to deliver predictable outcomes. Now, if I was going to make any claims to an ultimate capital T truth, I'd say that biochemistry doesn't lie. Molecules do what molecules do, regardless of what human beings say about them. But biochemistry is remarkably complex. We can study it, we can get the data, then we have to interpret the data. And that's just on the level of cells. This is what's happening in cells. And most of the time, we can only deal with, one little tiny fragment of it, of the whole big, horrible, complicated picture. And when it comes to humans and their nutrition, it's actually even more complex than that. So here's another example of the importance of the viewing lens, in this case, a conceptual viewing lens. This is a paper that came out this year on specification curve analysis, and I'll explain what that means. And the authors use an example from nutritional epidemiology and studies of red meat, which are notoriously unreliable. Now, we all know that red meat will kill you. At least that's what many health authorities would have you believe. However, the authors of this paper note the inconsistent findings from many different epidemiological studies of red meat on all-cause mortality, and they observe that these inconsistencies might have something to do with the way the data is analysed. And this is called the challenge of analytic flexibility. They note that there are many ways to analyse data, and that what you see, what you find, depends on the variables that you use. So what these authors did was they chose one database, an NHANES database. In specification curve analysis, the researchers highlight the many possible ways of analysing data. So in this case, they examined one database that had a bit over 10,000 participants. They defined the core variables, and then they found that there are another 47 optional variables. And then they calculated that there were 10 quadrillion possible combinations of variables that could be used for analysis. That's a 1 with 19 noughts. They selected or specified combinations of variables, and then they performed over 1,400 unique analyses. They thought 10 quadrillion was a bit over the top. They excluded the implausible results, so they came up with about 1,200 plausible results, and they calculated the hazard ratios for red meat and all-cause mortality, which varied all the way from 0.51, meaning red meat approximately halved all-cause mortality, to 1.75, meaning that red meat increased all-cause mortality modestly. And by the way, the majority of the statistically significant results found in favour of red meat. So from one database, they had 1,200 different results. And yeah, it's a crappy diagram, it's a bit hard to see, but basically what it shows is that along the y-axis are the hazard ratios, and each dot along the x-axis represent an analysis. Most of them cluster along 1, which is the line of no effect, meaning that red meat had no effect on all-cause mortality. The blue dots on the left are the studies that showed that red meat reduced all-cause mortality, and on the right, the red dots showed that red meat increased all-cause mortality. And the point here is not whether red meat will kill you or not, but that there are many ways to analyse data, and researchers' selection of variables determines what they find and report. As a researcher, you can choose the variables that give you the results that you want. As a reader, next time you come across research that damns red meat or fat or eggs or low carb, like the study that Dr. Bruckner talked about yesterday, consider how many possible analyses might show the opposite truth. So I wonder what results we'd get if we subjected that Kabtheimer et al. Study, the study that Dr. Bruckner was talking about last night, if we subjected that to a specification curve analysis. Anyway, this paper on specification curve analysis, I think, is a wonderful example of perspective knowing. And I reckon perspective knowing applies to many different kinds of knowledge. My interest is in what we know to be true in low-carb medical practice. And I'm a clinician, so I'm very focused on what I need to know as a practitioner. So let's explore concepts of truth, trust and evidence in the context of medical practice. So here we are in a consultation, and there's an awful lot of assumptions going on in the room at the moment about doctors and patients in clinical encounters. We assume that the doctor-patient relationship is based on trust, that patients trust their doctors, and that the doctors are knowledgeable and trustworthy, and that the doctor has access to reliable information, which we think of as truth, and that the medical paradigm is superior to those other healing paradigms because medical science is truthful and evidence-based. So let's look at evidence-based medicine. The acronym is EBM, and its contemporary manifestations follow clinical guidelines. So this talk grew out of my own long-standing interest in epistemology, but also last year Ron Schweitzer and I were the GP advisors to the Defeat Diabetes study. And we ran education sessions about low carb for the GPs who had patients enrolled in that study. And a lot of those GPs had no familiarity with low carb. And some of those GPs were concerned about going against the guidelines, meaning if a patient had an adverse event, such as a heart attack, while they were enrolled in the Defeat Diabetes study, would the GP get the blame because they were recommending this crazy high-fat diet? So guidelines are now at the centre of the modern medical episteme. And this is what I'm questioning. Are modern medical guidelines trustworthy? Are they relevant? Should doctors follow guidelines? What happens if we don't? And how do we know what to do when there are conflicting guidelines? But most of all, how on earth did we get here to the point where GPs are in a panic about whether they'll be targeted if they don't follow the guidelines? So we need to know more about the history of guidelines and the EBM paradigm. And this quote is from a 2014 paper by Professor Tricia Greenhalgh. She's an academic GP in the UK. And her appraisal of EBM starts with pointing out that 30 plus years ago, EBM aimed to replace tradition, anecdote and mechanistic studies from basic sciences with evidence from high-quality RCTs. So at first, EBM encompassed what I think is some really great ideas, like the desire for the best available evidence to inform clinical decision-making, as well as the democratisation of knowledge. In theory, everyone can learn how to appraise the studies, and voila, we can all get rid of mere opinion. We can all use the best evidence to make everyone healthy and happy. Then we can all go home, live happily ever after. Although, as we know, that's not actually what happened. Ron's response to the concerns from the Defeat Diabetes study GPs was to point out that there are guidelines that endorse low carb as an option for people with type 2 diabetes and other metabolic conditions, and he's entirely correct. And here are some examples relevant to low carb, and in fact, an earlier speaker today did pop up a whole lot of relevant low carb guidelines. I personally think that this one, the Diabetes Australia position statement on low carb eating, is very tepid. It defaults to lean meat, low-fat dairy and whole grains, and it demonises saturated fats, i.e. it ain't low carb. And there's other more enthusiastic guidelines, such as the consensus report from the American Diabetes Association with that famous quote. We've already seen that once to this conference. Reducing overall carbohydrate intake has demonstrated the most evidence for improving glycemia. And there's also the Society for Metabolic Health Practitioners guidelines. But you know, these documents have very little traction amongst mainstream doctors in Australia. which actually raises a question about what evidence is admissible by the mainstream, and I'll come back to that. My approach was to question guidelines that are promoted by terribly conflicted peak bodies and that use evidence that's way past its use-by date. Back to the history of EBM. It emerged about 30 or more years ago from the Dark Ages when people went to the doctor for an opinion. EBM was going to rescue patients from mere opinion and tradition and standardise medical interventions so that everybody got the best treatments and outcomes, predictability. Instead, we ended up with mountains of guidelines. Interestingly, when I was a GP trainee in 1999, EBM was the buzz phrase, and trainees were encouraged to learn skills to critically appraise research papers. And that was partly to counter the pernicious influence of drug reps detailing the latest statin drug with its impressive relative risk reductions. So I learned about concepts such as absolute risk reduction, relative risk reduction, and number needed to treat. And these are metrics that I pay attention to when I'm reading the medical research. These days, I'm told that GP training is all about guidelines. You or your doctor follow the guidelines or else. However, EBM is not without problems, and this is Professor Greenhalgh's list of concerns with EBM, including too much evidence, the irrelevance of guidelines to people in the real world, that's the problem of complex comorbidity, a focus on numbers rather than the whole person, and the top point there is the evidence-based quality markers being misappropriated by vested interests. And I'm sure that all of you here are well aware of who pays for the science. And this is where I'll shout out to all those who've helped to expose the corruption of science by industry. So, should GPs follow guidelines? The debate about the use of EBM in medical practice is not new. Back in 2014, a stroppy GP from Glasgow questioned how well the UK guidelines fit patients in general practice because most large research studies are done on carefully selected populations. People with complex comorbidities are underrepresented in clinical trials, but they're also the people that we see most of in general practice. She points out that only 38% of studies used in the official UK National Institute of Health and Care Excellence guidelines, the official UK guidelines, are based on patients typical of those managed by GPs in the community. And I reckon that this probably applies here in Australia. So there's lots of problems with clinical guidelines, and this is a very short list. And the thing that I want to highlight is that by the time they are published, most guidelines are out of date. And speaking of irrelevance, this is a page or a section from the RACGP's Handbook for GPs Managing Type 2. It was published in 2020. There's an update due any moment now. And it barely mentions low carb. I've highlighted one mention here on page 193 because otherwise you'd probably miss it. And these guidelines, which GPs are supposed to follow to manage people with type 2, default to the Australian dietary guidelines, meaning low-fat dairy, lean meat, whole grains, even though, as we've already heard today, the Australian dietary guidelines are not intended for people with chronic disease. And I suspect that the updated version of the RACGP handbook will be no better. The reason that we have guidelines is because mere clinicians cannot be trusted to analyse data. We're too busy dealing with sick people. We're time poor. So in practice, EBM has had the opposite effect to democratising knowledge. It's concentrated expertise with medical statisticians who have the skills and the time to analyse. We clinicians simply have to trust the experts, follow the guidelines, and don't ask too many questions. So I'm not throwing the EBM baby out with the dirty big pharma bathwater. I love looking at research, and I'll use the rest of this talk to show how I make sense of knowledge and evidence in my low-carb practice. So first of all, here is Prof. Greenhalgh's version of real evidence-based medicine. And the 2 points that I want to take from this is that evidence needs to be discussed with the patient in the context of a strong clinician-patient relationship, i.e. one based on trust and mutual respect. And evidence-based medicine is not mechanical rule following. And perhaps I should repeat that. It helps to remember that guidelines are maps. They are perspective knowledge, an incomplete guide to the territory. They are not the territory. If you're a bushwalker, you'll know that when you're out bush, you need to have your wits about you, paying attention both to the map and the territory. So how do doctors manage this problem, which is the inevitable mismatch between the map and the territory? And at some point, clinicians and patients have to make decisions and take actions, often with incomplete information and imperfect maps. Real life and clinical practice is a swamp. It's messy and it's unpredictable, and our maps are far from perfect. I think this is what David Sackett was getting at in this classic paper in the BMJ from 1996 on evidence-based medicine, what it is and what it isn't. The diagram there summarises what's in the fine print on the left. The ideal is the best available evidence, which is the map, clinical expertise and judgment, and patient preferences and values. But you know, it isn't always like that in clinical practice, which still brings us back to the questions of what counts as evidence, who decides what counts as evidence, whose clinical judgment, and if you're a patient, how often do your doctors take your preferences and values into consideration? So here's a clue. Evidence is what the EBM experts say count as evidence. In the EBM world, they have both kinds of evidence, systematic reviews and meta-analyses. That was a joke, by the way, but it's actually not far from the truth. In the words of Prof. Greenhalgh, evidence is what powerful people say it is. Despite 30 plus years of evidence-based medicine, we are still in the hands of experts because GPs and patients cannot be trusted to interpret data. So we have a slew of experts producing guidelines that we're expected to follow and trust because they are the experts. The EBM cult has produced pyramids of evidence, and they all look pretty much the same, with systematic reviews and meta-analyses and randomised controlled trials high up on the scale of what counts. They really do discount and ignore anecdotes and basic sciences, just as Prof. Greenhalgh observed back in 2014. EBM and expertise in interpreting data have captured the modern medical episteme. They are the people with the monopoly on capital T truth. Consequently, the current medical and nutritional episteme have bad cases of blind spots and tunnel vision. They just erase the bits that they don't want to see, like meat, eggs and cheese. And loads of low-carb data and evidence is discounted. And I reckon the Australian Dietary Guidelines are a really great example of tunnel vision. So if anyone tells you there's no evidence for low carb, they're actually not looking. Now, let's go back to the EBM triad with the idea of perspectival knowledge in the front of our minds. My next big claim is the idea that the only useful evidence is from randomised controlled trials, systematic reviews and meta-analysis is really very dumb. There are plenty of other kinds of evidence out there that can contribute to our understanding and help us out in the real world of illness and suffering, chronic disease and complex comorbidity. So I'm arguing for a broader vision of what counts as evidence. Dr. Unwin addressed this in a paper published earlier this year. He starts with a version of the usual evidence-based hierarchy over on the left, figure 1, and he's added in down below in figure 2, patient experience. Yay! But it's still a hierarchy and it still privileges systematic reviews and meta-analyses by putting them at the top, and it doesn't include basic sciences such as in vitro studies, animal models, cellular mechanisms. So to Dr. Unwin's work, I'm adding in two concepts from an obscure 2001 paper by an obscure author, Stephen Butoff, from an obscure country. And the concepts that I've snaffled, it's no longer obscure now. I'm putting it on the map. Two concepts that I've snaffled, the medicine of meaning and the multiple pillars of evidence. And medicine of meaning is the idea that the purpose of medical practice is healing and helping. And that we should not be, the idea of multiple pillars of evidence argues that we should not be beholden to the narrow perspective of modern medicine. In the words of Nietzsche, back in the 19th century, we need many eyes, different eyes, to examine and deal with the problems that our patients present with. I'm not suggesting that we go back to, say, shamanic healing, but I'm suggesting that the medical episteme needs to get a broader view. So I've flipped Dr. Unwin's diagram. So now it looks more like pillars of evidence. Meta-analysis is no longer privileged over other forms. It counts patient experience, case reports and case series as importance. And you'll notice that pillars support each other. And this is, I think, the consilience of evidence concept. But I still think there's something missing there. And so in my expanded version, which I'm sorry you can barely see, I've added in over on the right, basic sciences, biochemistry, molecular and cellular biology and animal studies, because I think we ignore basic sciences at our peril. The Big Pharma does not ignore basic sciences. Big Pharma is very focused on research which identifies all those molecular pathways as potential targets for new drugs. So why the hell do we expect doctors to ignore the basic sciences? We don't always have top-of-the-range evidence like a meta-analysis of randomised controlled trials for every health condition, but that shouldn't stop us from looking for other pillars of evidence when we are working with someone who is suffering. If the basic biochemistry is sound, if you have some experience and you're working with a patient who has certain preferences, you might choose an intervention that isn't endorsed by guidelines, especially if they have a condition for which high-level research and guidelines are lacking, or perhaps, frankly, wrong. And if you're a graphic designer out there, feel free to take this graphic and make it look pretty. But the point being that low carb has multiple pillars of evidence, even if the EBM experts ignore it. And we are challenging and we are changing the paradigm. And how do I know? Well, I spend my copious free time looking at the literature, but don't take my word for it. I think you need to check the literature out for yourself, whether you're a patient or a doctor. And here's one example that I came across recently, 300 and something references, and look, I could have put up the ketogenic textbook from the Nutrition Network. I also think we need a historical perspective. We can learn a lot. Doctors are prone to dismissing last year's or last century's ideas as out of date, but perhaps they've forgotten or simply ignored ancient wisdom. And we don't just need evidence, we need powerful people with megaphones shouting out loudly. So I try to bring a broader perspective to my clinical practice, and here are some of the things considerations that I bring to consultations with my patients. What is the evidence for the intervention? What is the provenance of that intervention? Does it make sense? The costs, the pros and cons, blah, blah, blah. Patient preferences, likely benefits. And I try to be mindful of the blind spots, my own blind spots. I constantly get blindsided when patients say, oh, do you think this symptom might be a side effect of the drug? And I go, oh God, why didn't I see that? I'm a doctor, that's why. Every medical intervention is a trial of N equals 1, and I think N equals 1 is the most important data set. Life is uncertain, deal with it. The clinical data might say, yeah, this is predictable, people are not predictable. The stats give us means and standardisations, people are not standard, we're not average. And sometimes the most honest thing a doctor can say is, I don't know, but I'm also willing to look and think harder and learn and keep an open mind. Guidelines often have disclaimers. Over on the left is the disclaimer from the RACGP's Handbook for General Practice. It gives the college a no liability escape clause, but it also gives practitioners latitude to exercise clinical judgment. And even the appalling Australian Dietary Guidelines has this disclaimer over on the right on page 3. The fine print there says, the document is a general guide to be followed subject to the clinician's judgment and patient preferences. So all you low-carb clinicians out there, feel free to ignore these useless guidelines. And the problem with many of the guidelines and experts is that they are convinced that they have the monopoly on truth. And I'm arguing for open-mindedness alongside a healthy dose of scepticism, as well as a droplet or two of humility. Let's hold our truths lightly, because even the strongest pillars may fall. Now, I hope and pray that we are seeing the pillars of the low-fat paradigm crumbling. It might take another decade or two to be completely rid of it. But no doubt if we live long enough, we will also see new evidence challenging our cherished beliefs about low carb. So let's have the humility to be open to new truths and new evidence, because as the Buddha said, all things change. Now, if you like me and love talking epistemology, please come and talk to me. And that's where I'll wrap it up. Thanks for listening. And there are the references.